Next, we will be hearing from Dr. Anna Kagan. Dr. Kagan is the Clinical Service Chief of Nephrology here at Houston Methodist Hospital. She is also a specialist in clinical hypertension and works as a transplant clinician sitting on the Transplant Medical Safety Quality Management Committee here. To settle the debate once and for all on neurons and nephrons, here is Dr. Kagan.
Thank you for that introduction and for inviting me. I think the debate will continue to go on even after my presentation. So what I want to talk about is chronic kidney disease and stroke. And that's sort of looking at a subset of population of this country and in general, and the challenges that that population presents when you talk about treatment and diagnosis of stroke. I don't have any disclosures. And over the next 15 or so minutes, we'll go through a couple of things. We'll talk about what is chronic kidney disease very briefly, just to get everybody on the same page. Talk about the associated risks of strokes between stroke and CKD, as well as the outcomes in patients with chronic kidney disease. We'll briefly talk about the mechanism of stroke and chronic kidney disease. There's a lot of stuff being researched, not very well understood in great detail. And spend a little, I apologize, and spend a little bit of time focusing on the challenges in the diagnosis of stroke, as well as care in patients with chronic kidney disease. If there's one takeaway point from all of this, is that patients with chronic kidney disease make stroke care and cerebrovascular disease significantly more complicated across every single aspect of it, from recognition, from diagnostic imaging, from treatment, from prevention. This is just a more challenging population that presents own problems. So what is chronic kidney disease? This is frequently used as a KDIGO guidelines to talk about what is chronic kidney disease. They're used based on calculations of estimated glomerular filtration rate. Sort of the new kid on a block in that is using cystatin-based calculations, not just the creatinine-based calculations. You'll see that many laboratories now will report both creatinine and cystatin-based GFR calculations. That's actually a big step forward in recognizing patients with chronic kidney disease, as cystatin doesn't depend on the muscle, and we actually are recognizing that more people have chronic kidney disease than I think we initially thought. It comes in 5 stages. I think most people don't really think about stage 1 and 2. That's very mild degree of chronic kidney disease, and frankly, bulk of population has that. Stage 3, 4, and 5 becomes more problematic, and then stage 5 is when we'll usually talk about dialytic therapy, which presents its own problems in stroke care. It's very common, so somewhere about 15% of United States population has chronic kidney disease stage 3 and above, so we took away stage 1 and 2. This is just stage 3 and above. And as you can see, it also is a little bit dependent on race and as well as gender. It's actually Black males have the highest risk of chronic kidney disease in the United States. If you look at who has chronic kidney disease and who has strokes, the risk factors are actually incredibly common, right? If you were to overlap the populations, very common: hypertension, diabetes, smoking, hyperlipidemia, drug abuse, atrial fibrillation. These are all conditions that lead to vascular issues. And when it comes to blood vessels, kidneys and brain have pretty similar in structure blood vessels. So very common population, multiple risk factors. But when you control for all of the other risk factors, chronic kidney disease in itself increases the risk for stroke regardless of all the other common risk factors. In fact, when you look at the population, there's approximately a 7% increase in risk of both hemorrhagic and ischemic strokes for each 10 milliliters per minute decline in GFR. So 7% increase for each 10 mil per minute decline. Protein in the urine, albuminuria, in itself also increases the risk of stroke, and it's about a 10% increase for each just 25 milligrams, pretty small amount. And interestingly, those populations are not exactly the same. There are patients where it's clearly that they decrease GFR as well as in albuminuria independently associated with risk of stroke. So those who have both impairment in filtration and proteinuria, they're at a much higher risk than those who just have one or the other. Dialysis population. So clearly that is a very special subset when it comes to stroke. very high increase in risk of stroke, anywhere between 2 and 10-fold increase, both for ischemic as well as hemorrhagic strokes. There's also a lot of microvascular hemorrhagic disease as well. The risk actually starts going up a few months before people start dialysis. So it's not purely associated with dialysis treatments. In the first year, there's approximately a 7-fold increase in the risk of stroke after starting dialysis. And the first months after dialysis, even though the risk goes up 3 months before starting dialysis, the first months after initiation of dialysis is sort of the highest time that we see strokes. A lot of times this happens right after dialysis treatment, and that's where the diagnosis becomes a little bit more challenging. It is not uncommon for people to come off a dialysis machine feeling a little bit off, having a little bit of symptoms, and therefore a lot of times it's assumed that they're gonna have something because their blood pressure was low, they didn't feel as well. Well, they actually might have had a stroke, right? So it's a very common time to develop a stroke, and unfortunately it's a very under-recognized time, which then has a downfall effect of not being in window for treatments. And the risks are independent of dialysis modality. I'll spend just a moment on that. You know, I think we all think about hemodialysis. You run the blood through a machine, the blood pressure drops, everything happens. Everybody thinks, well, you're just not going to perfuse your brain as well. You have already vascular disease. The risk of stroke should be higher. That's actually not true. Both hemodialysis and peritoneal dialysis, which is generally sold as a milder therapy, have similar risks of stroke. So it doesn't just have to do with perfusion. There are, interestingly now, some studies where in a very small populations of hemodialysis patients are starting to look at TCDs, transcranial Dopplers, to see if it's possible to identify populations that may be at a higher risk of developing stroke with hemodialysis and fluid shifts. So again, and this is independent of modality. Typically, the hemorrhagic strokes, at least early on post-initiation of dialysis, are a little bit more common than ischemic strokes. Transplant. You know, everybody talks about the benefits of transplants, and those certainly cannot be ignored. Cerebrovascular disease is one of the few conditions that once you develop it, transplant doesn't save you as much. So if you look at other causes of mortality, other deaths of years post-transplant, as you go forward with transplant, those curves come together. With stroke, if you have cerebrovascular disease, there is still going to be risks of death even if you've had transplants. So they help, but not, transplant helps, but not completely. All right, outcomes. So you have your chronic kidney disease patients, you have your dialysis patient, they had a stroke. They don't do as well. I think everybody in this audience knows they just don't do as well. They don't recover as well, they stay in the hospital longer, their mortality is higher, the rehospitalization is much higher. And they definitely take on a fair amount of care that's required for them afterwards. Why is the chronic kidney disease population so challenging in terms of cerebrovascular disease? And really there is no one answer, and this is not an all-inclusive list at all. You know, we initially all think about cerebral blood flow, right? That's a big component of what happens. And of course, the autoregulation is affected by chronic kidney disease. The blood vessels of patients with kidney disease are just not the same anywhere. They're impaired. They have endothelial dysfunction. They have more calcifications. They have larger plaques. The large arteries look much worse than they do in a non-CKD population. There's also a pretty significant increase in risk of atrial fibrillation. So if we look at general population versus patients with chronic kidney disease, and especially in dialysis, you know, studies report anywhere to 2 to 10-fold increase in the risk of atrial fibrillation. And I've seen even some studies that show 1 out of 3 or 1 out of 5 dialysis patients have actual atrial fibrillation. Sometimes it's maybe paroxysmal, but they do have it. So it presents a different physiology a little bit, but also a different challenge in therapy of those patients. There's definitely increased risk of small vessel disease, and there's quite a large population that have APOL1 genotype mutations that are associated with that. Platelet dysfunction that I'm not going to talk in front of Dr. Petkova, but we know that uremic platelets don't do as well as patients who don't have uremia, and chronic kidney disease affects platelets as well. And then medications. Majority of patients with chronic kidney disease, even if they're not on dialysis, will be requiring to receive some medications to increase their hemoglobin. The erythropoietin-stimulating agents are a known risk factor for stroke. This has been known ever since they hit the market. This is the black box warning associated with that. There's now actually some studies to show that there's things you can do to mitigate those risks, and that is actually providing adequate iron supplementation. So by using adequate iron supplementation, don't typically need to give such high doses, and it maybe decreases the risk in that particular population. So some good news there. All right, so what are the challenges? I briefly mentioned some of them. Again, delay in recognition is a huge one, especially after dialysis. Everybody assumes that somebody is going to be sleepy after dialysis. Everybody assumes that they're not going to be moving as well. Everybody assumes that they're going to be a little bit slower to respond. Not always normal. Unfortunately, patients with chronic kidney disease, and this is not just in cerebrovascular disease care, but across all other illnesses and conditions, are frequently excluded for clinical trials. It's not as easy to do imaging on them, higher deaths. You know, they're challenging populations, and hence that population is not studied as well. So a lot of things that are done is extrapolated from a general population, which we of course know is not the same thing. There's always a delays and hesitancy in acute management. This actually is a little bit more towards patients with chronic kidney disease, not those already on dialysis. But there's always worries about giving that contrast. What's gonna happen? Well, if you think you have a stroke, give that contrast. You know, kidneys will do what they're gonna do, right? This is your time. But there's always that hesitancy in doing testing. We'll talk about that in just a moment as well as treatment, right? People worry about bleeding. The thrombolysis and antiplatelet therapies are frequently, patients are either out of the window for therapy or they're considered to be not candidates for that. Risk factors are much more difficult, right? Blood vessels of chronic kidney disease patients are not the same as blood vessels of everybody else. More calcification, more oxidative stress, much more difficult to control some of those risk factors. All right, radiographic challenges. So we actually do have a little bit of good news in there, and that's an MRI arena. Of course, everybody worries about what's going to happen if you give iodinated contrast to a patient with chronic kidney disease, especially in later stages of chronic kidney disease, not on dialysis. Everybody worries about contrast-induced nephropathy. It's definitely a worry, but you know, this is neurons definitely supersede the nephrons in this particular one. So save the neurons, we'll deal with the nephrons later. The MRIs is actually good news for us, and that is the majority of radiology departments across the country have changed the gadolinium-based contrast agents that are now no longer thought to be associated with nephrogenic systemic fibrosis. As you, of course, many of you know, for years and years and years, anybody who had chronic kidney disease stage 4 and above, everybody was really afraid giving them MRI contrast because of the risk of NSF. It's a real disease. It's a terrible disease. It's a high mortality disease. But these new agents actually are quite safe, to a point that the rheumatologists and nephrologists came together to come up with radiologists and nephrologists came together to come up with a joint statement saying, please go ahead and give those agents. Don't worry about it. Don't delay it. And you don't really need to dialyze after that. Some programs still use dialysis after contrast administration in the dialysis patient as a requirement. Houston Methodist still does that, but there's not clear-cut evidence that you absolutely need dialytic therapy after receiving contrast for gadolinium. Thrombolysis. All right, again, underutilized, not very well studied. Many times by the time these patients present and actually are diagnosed, they're out of the window for anything that can be given to them. Many times they come in with astronomical blood pressures, which is not unusual for our dialysis population, but they're contradictory to the use of thrombolytic agents. Those who do receive thrombolytic agents intravenously don't tend to do as well, right? Increases the mortality, so it's not an easy population to treat. Over the years, there's been now some thoughts that even the endovascular approaches, those patients, the chronic kidney disease patients tend to actually do probably similarly to what the patients without chronic kidney disease do. They do have general increased mortality, increased risk of complications. Those who come in with acute kidney injury at the time of the stroke diagnosis are actually the ones who do the worst, right? So something is happening at the time. They tend to do the worst. They don't tend to recover as well or recover the neurologic status as well. But the bottom line is, you have a patient with stroke, they're chronic kidney disease patients, you treat them, you know, if it's needed, you treat, right? Neurons here definitely save the nephrons here. On the preventative side, another challenging approaches. So aspirin, and some of this has been addressed in other probably talks, but aspirin and primary prevention in chronic kidney disease patients thought to be not to be very useful. Secondary prevention definitely appropriate. The anticoagulation, especially in a population with atrial fibrillation, becomes a challenging question what to do in that. Definitely early stages of chronic kidney disease, maybe even including chronic kidney disease stage 4. Certainly the benefits of therapy outweigh the risks. As you go towards the latter part of CKD stage 4 into CKD stage 5 and dialysis, the question becomes what is the risk-benefit ratio in that situation? And generally, at least the move now in the literature is to go towards DOACs for treatment as opposed to coumadin-based therapies. The dual aspirin and anticoagulation does well in the early stages of chronic kidney disease, definitely appropriate again as we move towards the dialytic therapy and advancing stages of chronic kidney disease. It's becoming a little bit more difficult. The lipid-lowering agents, and I'm sure Dr. Patel will address that as well, are definitely good for CKD patients. ESRD patients, the KDIGA, right, which is kind of our guidelines, actually don't suggest initiating denovastatin at this point. Things may change as other therapies are studied in that population, but at the moment it's thought to be not to do that. Blood pressure control definitely much higher. Not just in dialysis patients, you know, blood pressure of 200s, 240s is not unusual in dialysis patients at times. But even in chronic kidney disease patients, it's much harder to control blood pressure, much more challenging to control the volume status, which plays a role in that. As well as especially in patients with chronic kidney disease, we can't use all the agents. A lot of our patients cannot use ACE and ARBs, which may be protective and may be good selection in other populations. And then the carotid vascularization in a secondary prevention as well in that population probably is of benefit. So in a sort of short span of time, I sort of took you through the challenges we face as nephrologists working together with neurologists to figure out how to best treat this population. It's a common problem. Stroke is very common in our population of patients. These patients, unfortunately, do not receive sometimes adequate care just because of their frailty and sometimes issues in both diagnosis and treatments that can be offered for them. Definitely much higher morbidity and mortality population. As mentioned, hard to treat, hard to diagnose, hard to know how to follow with these patients, and limited clinical trials, of course, to guide any evidence base. That also is some improvement, I think, across, because CKD is now recognized as such prevalent disease, across all disease states, not just cerebrovascular disease. I am seeing that CKD patients, especially CKD4 patients, are now more involved in the trials. So this is the positive part. This is the hope that in the next few years, in the next decade, we'll be able to say that the treatments that are appropriate for CKD patients were actually studied at least in a subset of CKD population, that we understand the physiology and pathophysiology a little bit better. And with that, I'm gonna